Hello, good evening, everybody. I am Jayant Umranikar, Chairman of the International Longevity Center, India. On behalf of International Center, it's my present responsibility to welcome you all for this function. India's theme for G20 presidency is Vasudhaiva Kutumbakam, one earth, one family, one future. And when we talk of family in India, it includes old parents and grandparents also. India wants to build global consensus on various global challenges across G20. One of them is global health, and that includes the challenge of healthy aging also. And when we talk of healthy aging, we in ILC believe we have to add life to age rather than age to life. There's a need for a united global approach to healthcare to create a system that is universal but affordable also. ILCI is doing its bit to raise the awareness on this issue at various levels. Once again, when we say affordable, in India, it means getting more from less for more. Today's event is part of that effort. We'll discuss the benefits of healthy aging. We have eminent speakers and we have well-known experts in the audience. Without much ado, I welcome you all and hand over the stage to Mr. David Sinclair and the mic also.
I stole your mic. Great. Thank you. Thank you very much. Thanks very much, and look forward to hearing from you in a moment. I'm David Sinclair from the International Longevity Centre in the UK. We are the leading authority, the UK's leading authority on longevity and the impact on society. For those of you joining us online, welcome to India. And for those of you joining us here, you will benefit from some food and drink afterwards, which the people online won't. I should say I'm excited and delighted to be here, just not very far away from where our G20 Health Ministers are gathering over the next couple of days. So this is a great opportunity for us to, I hope, sort of, prompt some real discussion and thoughts on this really important issue. And I should say this is my first time in India, and I'm only here for 3 days, which I'm very sad about. But 25-ish years ago, I had the pleasure of studying, I don't really know, someone in the Welsh examining body obviously was very passionate about India. So I studied a whole exam on India and Indian geography, which was fascinating. I think we went beyond colouring in maps and things like that. It must have, and it was obviously taught from a UK perspective, and it was all about the Green Revolution. But since that, I've always wanted to come. So anyway, I'm glad I'm here to see a little bit of India. I'd just like to thank quickly our sponsors: Amgen, GSK, Hallmark Foundation, MSD, Pfizer, and Sanofi, and also just to let you know that we're part of the Global Alliance, the ILC Global Alliance, of which ILC-India is one. There are 16 partners across the world who all work together loosely in all sorts of different ways, and it's great to actually have this network. So why are we here? Why are we here? Of course, partly because we have some health ministers coming together, partly because we think that the prevention of ill health in the context of an aging society is extremely important, and that actually we want to convince governments to invest more in this. India is, I don't need to tell those of you in the room this, but now the most populous country in the world. The number of people aged over 50 is due to double by 2050. So there is, even though it's a relatively young country, it is aging like everywhere else, and there is some good news since 2000. Aaron will talk a bit about the index and how actually the countries that have improved most over the last 20 or 30 years on our index are not the countries at the top. They're the countries that were lower down on the index historically. And in India alone, for example, since 2000, we've seen a 7% increase in life expectancy, 8% increase in the number of people in good health. So there has been some real progress over the last couple of decades. There's also one of the things we're in the UK particularly interested in is the economic contribution that people of all ages, including older people, make. In India, half of those aged 50 to 69 are still working. And actually, I was surprised when I saw this stat, half of people aged over 65 in India volunteer more than any other G20 country. So real contributions being made by older people already. But on the other hand, India only spends $16 per head on prevention and 211 on health, which is the lowest in the G20. And what we know is that the more you invest in health, the more economic return you get from doing so. So we're here to sort of spark that conversation. The plan for today is we've got some brilliant speakers. We're going to talk a bit about our index, and I'm going to pass to Aaron in a moment. We're going to talk a bit about life course immunisation and the role of the role of that as an example in the context of prevention, and here's from some real experts. For those of you who are joining us online, there is a chat function and you can put some questions in the chat function on Zoom. And if you are using Twitter, please do put a hashtag, use the hashtag at ILC-UK and Prevention Index. I'm going to stop there and pass immediately over to Aaron to talk through our index. Thanks.
Hello. Hello. Hi, everyone. Grateful to be here today. Oh, sorry. Checking. Should I try your microphone? Okay. All right. Hello? Okay. I might need to move. Apologies. Okay. All right. Stand over here. All right. Okay, hopefully this works and I don't have to move too much. I'll try and stay in the same spot as much as possible. But grateful to be here. I'm just gonna try and change the slide. I might need a bit of help with changing the slides at the back, if that's okay. I'll let you know when you move on to the next slide. But as I mentioned, I'm Erin Himawan. I will be today presenting on our Healthy Aging and Prevention Index. Can I have the next slide, please? So a little bit about our index. So the Healthy Aging Prevention Index essentially ranks 121 countries for the first time on 6 healthy aging metrics. It's an online tool that you can go online to see how various different countries rank. We look at 6 different metrics across health, society, and including wealth. Why do we look at different types of metrics? Well, the main key reason is that we recognize that when it comes to healthy aging, it isn't just about health, but it's also about how long people work for, how much money are they making, are they living in a good environment, are they happy? So all these various metrics together, we believe, are sort of key issues that governments do care about and want to see their countries perform well on. So this index essentially, in addition to ranking countries, also ranks political and economic groups. And I will talk a little bit about that later on, but it also includes groups like the G20. Next slide, please. Fantastic. So on our index, what we find is actually there's quite a lot of inequality between those at the top of the index and those at the bottom. What we find is that with an average population of only 8.4 million, the top 10 countries account for only 1.1% of the world's population. So what we're seeing is that actually a very small group of people are benefiting from healthy aging and longevity. And so we want to really be able to tackle this, address this, and ensure that more people can benefit from living not just longer, but healthier lives as well. Next slide. We also see that there's quite a bit of inequality across the specific metrics. So if we just take the first key metrics here, so that's lifespan, health span, and work span, we see that there's more than a 20-year difference for each of them, 24, 21, and 23 between the top and bottom 10 countries on the index. So again, huge inequalities, and this is something that is worth keeping in mind when we're thinking about how different countries are aging. Next slide, please. Thank you. So these are the top 50 countries, because I couldn't fit 121 on here. I tried. But what we can see is there's about 13 of the G19 countries, excluding the EU, that sit in the top 50. And we have India that ranks at 102. And I'll talk a little bit about why India does rank in this position. And I think it's quite a complex story. And certainly there's a lot of improvements that we've seen in the country. But of course, there's lots of issues that it is facing that I think is not just specific to India, but also other G20 countries are also facing when it comes to healthy aging. Next slide, please. Great. So before we get sort of into the deep dive into the G20, I thought I'd sort of start off first by looking at where the G20 sits across the other political and economic blocs. So we look at 9 in total, and we see that the G20 ranks in the 8th position. It actually does particularly well in lifespan and health span and work span as well. But when it comes to income, environment, and happiness, it doesn't do as well. But what you can really sort of see, even just with the small number of groups that have been ranked, is that all of these metrics relate to one another. You can see with the sort of the mapping that we've done here, the heat map, countries that countries that do better on the index, or country groupings that do better on the index, tend to also have higher on average. All 6 metrics tend to be higher. So there is certainly relationships between these 6 metrics. We haven't picked them out sort of from blue. We recognize that they do impact on one another quite strongly. Next slide, please. So if we look at the this graph here, this table here, we look at the top, we look at the G20 countries here, and actually I believe India's hiding a little bit at the bottom here, so I don't know if we can move the closed captioning a little bit. Fantastic. So what we see is that India actually does particularly well for lifespan and also health span. And this is not surprising. We've actually seen quite a bit of improvement, not in just the last 2 decades, but it's actually a much wider trend over the last 5 decades, where we've seen lifespan and health span improved by 7 to 8% over the last couple of decades. So that's really something that is certainly commendable, and we are seeing significant improvements on that. But of course, with the other metrics, we see that India is lagging. What you can also see quite clearly here again is also the trends between the different metrics from countries that rank at the top. So we have Australia, which ranks globally 6th, but ranks number 1 of the G20 countries. And of course, this is important to keep in mind that this is based on a certain point in time. So we're using data from 2019. We're keen to look at to include more data and to see over time how different countries change in their ranked position and why they actually might be improving or doing worse. We'd like to unpack that a little bit more to really understand what's going on there. Can I get the next slide, please? Fantastic. So what I think is really clear and an important point to make is that we know that it's not just about health, it's about the wider impact that it has. And we've done a bit of analysis on this, and we see that actually when it comes to things like preventable conditions, it's actually affecting our productivity quite significantly. Across the G20 on an annual basis, the economy is losing over $1 trillion due to yearly productivity loss, just among those who are aged in the 50 to 64 year age bracket. Conversely, it means that there's a lot that we can be doing by investing in more in prevention. We can actually see huge improvements to our economy as well. And we know it's not just about spending more and more on prevention. It's actually even just small amounts of investment can contribute significantly to G20 economies, and that includes India as well. We know that in India specifically, over 50% of those aged 50 and 69 are currently in employment. But there is still 50% of that population that, if we are supporting through proper healthy aging practices, we could actually unlock a much larger contribution from this age cohort. We also know that compared to other G20 countries, India spends the most of its older adults spend their time volunteering. They're sort of at the top of all G20 countries. So again, by supporting healthy aging, we can further unlock this potential that India clearly is demonstrating. So what we've also done with our index is we've compared it against various secondary metrics and issues that we find of importance. So what we've done here is we've mapped the index against prevention spend and also spend on curative healthcare. And what we find is that countries that spend a higher proportion of their health budgets on prevention generally perform better on the index. What's quite interesting is actually India does spend quite a bit on preventative health already, but it's just part of the picture. If we can go to the next slide, please. Great. What we can see here is actually we can look at the entire healthcare spending of India and all the other G20 countries, and we can compare that with prevention spend. And we can see India is all the way at the top there and spends a very small proportion of per capita spend on healthcare. It's about a 50th of that of the US's spend on healthcare, and about a 20th of that of Canada's spend on prevention. Canada spends the most on preventative health. So we're talking in absolute terms, very small amounts. So clearly there's something there in terms of spending more towards healthcare that could clearly be quite beneficial. And what we've also done is we've separately done analysis that looks at, by spending more in healthcare, does that actually improve countries' rankings on the index? And it does. We do see a relationship there. It is worth mentioning, though, spending is not the entirety of the issue. We also have to be clear on where that spending is going. So if I can get the next slide, please. One of the issues, of course, is around universal health coverage. And I think this is something that India can be quite proud about. In the last sort of 19-20 years, India's seen over 100% improvement in universal health coverage. And actually, it's the countries in the bottom part of the index that has seen the most improvement over the last couple of decades. So I think that's certainly something that we shouldn't forget about. But when we look at other issues when it comes to access, for instance, access to medical doctors, we find that for India, there's something like about, I think it's approximately 7 per 10,000. There's 7 doctors per 10,000 population. When we compare that with countries at sort of the top of the index and also in the top of the G20, that's more around 35 to 40 doctors per 10,000 population. So again, huge differences in terms of access to healthcare. So while there's certainly been improvements to universal health coverage, there's still, I think, certain improvements that need to be made, and there's still some ways to go. Next slide, please. Great. So what was quite interesting is we did a little bit of unpacking into sort of the social determinants of health, and education is one of those determinants that has a huge impact on health outcomes. And what we found is sort of, again, it's sort of a mixed bag story here, because India actually has the lowest average number of school years that an individual will be in school up till the age of 15. So on average, it's about 7.2 years. And that's below the G20 average, which is 11.5 years. But over the last 2 decades, India's actually improved by 2.1 years, and that's the 3rd highest improvement across the G20 countries. So while it is quite low, it has seen improvements over time, and that's something that we should not forget. Of course, again, like with access to doctors and universal health coverage, the same issue is around how do we actually push that number even further so that India isn't at the bottom. But like I mentioned, India, it's a complex issue in terms of how we actually address this, because on the one hand, we're seeing huge improvements, but we're also seeing India lag when it comes to final numbers and its rank on the index. So there's clearly things that we can do. And I look forward to hearing the other speakers on this topic. Could I have the next slide, please? Fantastic. So I'm just going to end here with saying that, so our index, the point of our index is really to hold governments to account. We want to be the sort of leading voice on preventative health and healthy aging. One of the things that we've done alongside the index is we've built a healthy aging and prevention coalition. And this is another way for us to hold G20 countries and also countries across the globe to account on healthy aging. And it's another way for us to say, look, it's not just us talking about healthy aging, but there's lots of organizations that actually agree that healthy aging should be a priority moving forward, particularly in the G20 global agenda, but also more broadly speaking. And so we want to continue using this as a tool to engage, continue doing more analysis, looking at how countries fare over time, so we can get a more comprehensive picture. And this is something that we hope to do in the next couple years. So I'll just leave you with a quote from one of our speakers in the when we launched our index, the Canadian Minister for Mental Health. And I think what's really great to see is that sort of positive response to the work that we're doing, but also recognition that even countries at the top of the index, there's improvements that they can be making as well. This is all relative. They're not getting it perfectly right. There's also things that they can learn from other countries. And hopefully this event can help us sort of unpack those issues a little bit more. Thank you very much.
Thanks, Darren. I think, you know, let me perhaps just I think there's something in actually your final graphic that every country improves essentially, and we need to use the index tool to do that. Let me pass over immediately to Mr. Amranika from ILC-India to talk a little bit more about the Indian situation and healthy aging.
Yeah, I think it's okay. So I'm going to talk about healthy aging in India and also something about my own organization. Next slide, please. So International Longevity Center India was established by Dr. S.D. Gokhale. It's a not-for-profit company, and it's part of a global alliance of 16 countries spread over five continents. We also have a satellite center for SAARC region, and United Nations International Institute on Aging, Malta, conducts its courses through our center. Next slide. Next slide, please. Yeah, this is the vision of ILC India, celebrating age and creating a society for all ages. Next slide. You will see the population is aging in India. At the moment, 60 plus population stands at 10.1%. And by 2050, it's likely to be twice that. So although we feel that India is a young country, ever young, it's not so. It's aging very fast. I think I will continue. Yeah, I can. Yeah. So population aging in India, I wanted to show some statistics, but the basic statistics are this, that the old age dependency ratio in India, it has risen from 10.9% in 1961 to 14.2% in 2011, and is further projected to increase to 15.7 and 20.1% in 2021 and 2031. The next slide is about the health status of older adults in India. And the findings are based on LASI, Longitudinal Aging Study in India, which was conducted by International Institute of Population Studies in Mumbai. And the statistics are quite revealing. We find that more the age, more the prevalence of NCDs, diabetes, hypertension, and vision impairment were found to be undiagnosed. Can you go to slide number 7? Yeah, this is LASI. Next. Yeah. The prevalence of dementia at the national level was estimated to be 7.4%. 1/5 of the Indian older population has rated their health as poor. And the highest cost incurred by the senior population is on hospitalization. Next slide. The titles are not visible, but on the left side you have what we have, and on the right side it's what we need. So India has specific policies and schemes for Indian older adults. Basically, you will find that there are provisions whereby there is subsidy given or financial aid given to various strata of the older population. What we need more than that is all aspects of national policy on older persons, and especially the implementation of those policies. The second problem faced is that of documentation. Documentation proofs of senior citizens. It's a very challenging task. And the third suggestion would be that we should have technology usage in tackling various problems of elderly population. Next slide, please. Government of India's policies and schemes for older people. We have a national policy on older persons of 1999 vintage. Then we have Maintenance of Welfare of Parents and Senior Citizens Act. We also have a National Health Policy of 2017, which basically takes care of geriatric health care and palliative care. We have social pension schemes, and we also have Indira Gandhi National Old Age Scheme, which is for the below poverty line citizens. Then there's a program called Avyay, a bit complicated in our language. The idea is to create a society in which senior citizens live in a healthy, happy, empowered, dignified, and self-reliant life with strong intergenerational bonding. Intergenerational bonding is very important in India because you find that we still have the family system, and you have at least 2 to 3 generations living together. So this is a very important aspect when it comes to Indian life. There are other schemes like Integrated Program for Senior Citizens, State Action Plan for Senior Citizens, Rashtriya Vayashri Yojana, National Helpline, and things like that. And then there are Antyodaya. These are all food-related programs. Antyodaya program, provision of food grains at highly subsidized rates. And then and there is Annapurna scheme. Once again, 10 kilograms of food grains are given to every person. This again is a preventive measure in India, because sometimes giving food itself is giving medicine. Overall, we have found that the Indian schemes, the government schemes are there. The problem is with the implementation once again. Our teams visited 3 primary health centers, initially known as PHCs, and we found that the medical officers and residential managers were overburdened, supporting staff positions were vacant. Rural, older adults were basically coming for diabetes, blood pressure, and arthritis. Cataract operations have been carried out in rural areas on a large scale. And that would say is one of the successful schemes in India. And we try to identify the needs. I think the first need is to create awareness regarding mental health, because none of these PHCs have any provision for mental health care. Young doctors will have to be encouraged to work in rural areas. And once again, digitization should reach the lonely older adults in India. Now, coming to the healthy aging and prevention index, you have seen that India does not really rank well. In the lifespan, it is 79th, health span is 83rd, work span is 98th, income is 79, environmental performance is 108, happiness is 112. And overall, we rank the last in G20 countries. I feel that the basic reason is that older people in India are still not a priority target group. The targets are still mother and child. So what we do is we have, ILC has programs and projects that are designed to alleviate some of the issues and concerns and ensure the well-being and empowerment of older adults in India. We work in the state of Maharashtra, which means that we are dealing with 120 million, roughly equivalent to the population of Japan. Next slide, please. Next. Yeah, these are the programs that we conduct. One is the physiotherapy assessment camps, where we promote strengthening of physical abilities. And we have at least 2 to 3 sessions with the same adults so that we can see if there is an improvement after we have given them the treatment. Then we also have a very popular program called Mobile Literacy Training Program for seniors. Basically, it's a 2.5 days program, and we teach seniors how to use their mobiles to remain connected with the world, to remain connected with their grandchildren who are in USA. And not only that, to get rid of the loneliness, how to entertain themselves, how to educate themselves, how to get medical aid with the help of mobiles and things like that. It's a very popular program, and we are running it almost every second month. Then we have online happy hours program, where seniors all across India can join in a webinar. And basically, it's a webinar series on mental and mindful abilities. We call it Online Happy Hours Cafe. Various things are taught there, including languages, memory enhancing games, mindfulness techniques, origami, and everything is in what we call infotainment way. Next slide, please. We also have some research programs. ILC conducted community-based pilot studies in Pune city on various issues. And we also have a study on COVID-19, which is available on our website. Another program is, as I mentioned earlier, being a satellite center for SAARC region. UN-India and ILC together hold international training programs. Till date, we have held 5 training programs. And the course is taught by an international faculty along with the nationally renowned experts. And a UN certificate is given to the participants of these workshops. Next slide. We have found that giving awards is a good way of creating awareness about an issue. So we have various awards. One award is a national award named after our president's mother, Anjani Mashelkar Inspiration Award, to felicitate the journey of an older woman over the age of 60 who has been through hardships and has overcome them successfully. Then we have another award called BG Deshmukh Award. BG Deshmukh used to be our cabinet secretary once upon a time at the center for excellence in promoting qualitative aging. This award is given to senior citizen organizations. In Pune itself, there are more than 600 plus senior citizen organizations, and overall Maharashtra also, we have many organizations that look after the senior citizens in the local area. And then we have the late Dr. S.D. Gokhale Award for promoting qualitative journalism on aging. Giving publicity to these issues is extremely important, and we find that this is one way of encouraging people to come out with articles on the issues and also come up with something useful on media, start a debate and things like that. And next slide, the last slide. So several NGOs in India had appealed to the government of India to include the issue of dementia in the G20 meet. We tried our best, but I'm not very sure whether dementia is being discussed. I feel that this is one issue that has to be discussed in detail much before it really hits us hard. Next slide. Just a next slide. Yeah. A way forward, these are some of the suggestions. India has a system in place, and the documents exist. Implementation is partial. It creates impact, but execution needs a multi-level support from the government, NGOs, and especially the community. Geriatric care centers, daycare centers, dementia care centers, well-equipped old age homes in metro cities are growing, but standard operational guidelines to maintain the standard is really needed. Then we have to encourage 45% 45 plus population to plan their post-retirement life. This we keep on conducting once in a while, post-retirement advice. Digital literacy among seniors across India is required to empower them. Healthy and active aging mindset must be imbibed among the seniors of all ages, and that's our effort in ILC India. Thank you.
Hi, great. Thanks. I love the idea of the online happiness classes. A friend of mine does an hour laughing class where they spend a whole hour every Saturday morning just laughing online, which seems like a fantastic idea. But actually, one of the things that it highlights, of course, is that, and that comes out of our work, is that some of the countries where people are the happiest and not necessarily where they're the healthiest, and vice versa. So there's an interesting discussion about, for all of us, about what do we think is most important here, which perhaps may come up in the conversation. Really delighted to have Stephen Hickling here who is the Deputy High Commissioner to Gujarat and Rajasthan. And thank you so much for joining us. And I will just pass straight over to sort of say a few words. Thank you.
Thanks, David, and thanks for having me. Ladies and gentlemen, esteemed panelists, thank you. It's a real honor to be here today to talk about aging. It's a subject close to my heart as I approach my 49th birthday, because I hope some of this actually comes true. And I live to be a healthy, happy person into old age. I've learned a lot already today. I've learned about the Healthy Aging Prevention Index. I thought was fascinating. I loved the idea of creating a society for all ages, which I think is an incredibly important objective. And I found the conversation so far to be incredibly instructive. One of the things that struck me about the last presentation was the conversation about digitization with elderly parents of my own. I can see both sides of the coin. I can see how digitization can make elderly people feel disconnected from the world. Whereas on the other side of the coin, it can be a very powerful tool, but I think it needs some careful thought. And I'd be interested to see more research in that area. I see with my elderly mother-in-law in France, she simply can't use a smartphone. So the projects that you described are incredibly empowering to those people in that position. I was lucky enough to visit India in 1997 when I was much younger, and I can see massive progress in India and huge development in India. Huge strides have been made, and in many respects, it's an entirely different country to the one I visited, let's be honest, in the last century. I think demographic change presents a daunting set of policy challenges and challenges to policymakers across the world, whether that's through service provision, such as school places for youthful populations, or tailored health provision for aging populations. As we've heard, the UK and India have very different demographics. The UK's population is aging fast, while India has what geographers and demographics experts might call a youth bulge. But while the UK has to grapple with the health issues that come with an aging population, India has to deal with a different combination of policy questions. But that said, as we've heard, the Indian population is starting to age fast. So I think we'll have some shared challenges on the horizon. But as our countries move through their respective demographic stages, the strong partnership between India and the UK should help us each to navigate the future. The UK's strong health and life sciences sector is playing its part. And as India's population ages, as surely it is, the UK experience coupled with Indian industry and ingenuity should help us to find innovative approaches to later life care and health. In the UK, there are various schemes to support the health needs of older people through a variety of actions, including the NHS health check and an ambitious prevention agenda to tackle the most common preventable diseases. So again, echoes of what's happening here in India. The UK is also focusing on the major factors contributing to early mortality, which reduce years of good health, including taking action to reduce the risk factors for cardiovascular disease that are also risk factors in vascular dementia. Again, tackling some of the issues that we've discussed already this evening. I've got to get an early night tonight because our Secretary of State for Health and Social Care, Steve Barclay, is arriving on the plane tomorrow for the G20 meetings. So I need to read the brief because no doubt he'll have lots of tricky questions for me in the car tomorrow. But he made a statement in January this year where he set out the UK's approach in a bit more detail. He acknowledged that the health and social care system faces long-term challenges in the UK, especially to ensure that the public enjoys healthier life for longer. And he undertook to publish, I think, a major conditions strategy. And that strategy will tackle conditions that contribute most to morbidity and mortality across the population in England. Scotland and Wales have their own similar systems under the NHS. So those are cancers, cardiovascular disease, including stroke and diabetes, chronic respiratory diseases, dementia, mental ill health, and musculoskeletal conditions. I nearly tripped over that word. He also set out a set of preventive actions through an office called the Office for Health Improvement and Disparity. And that's taking targeted actions to tackle the most common preventable diseases, working on preventive actions, improving access, embedding prevention across healthcare, such as encouraging people in midlife to stop smoking, reduce alcohol consumption, and improve diet. I've seen some of this in action because the last time I visited my GP, he told me I drank too much and I was fat. So I can see that these messages are being transmitted into the UK health system. Other preventive actions include screening, NHS health checks, as I mentioned earlier, smoking cessation packages, and focus also on secondary prevention, like prioritising the early detection of disease and supporting individuals to take responsibility for their own health through evidence-based public health and clinical interventions. In the UK, we've seen that advances in medical and social science have extended UK lifespans, as we've seen earlier in some of those excellent slides. We can reduce the risk of developing conditions by adopting healthier behaviours throughout the life of patients. Prioritising prevention isn't just about expenditure, but focusing on our efforts at the most opportune moments in an individual's journey through the health and care system. And then finally, non-communicable diseases are the leading cause of mortality in the world, representing 60% of all world deaths. So the UK strategy, preventative measures will help reduce these numbers, or at least that's the aspiration. So I'll conclude there, since you don't want to sit listening to a diplomat all evening. I love the phrase life to age, not age to life. That's going to stick with me, and I'm going to try and use that in a future speech. I thought that was a wonderful line. I also am going to introduce laughing classes at the British Deputy High Commission. We don't have enough of those, and sometimes we're all a bit grumpy on a Monday, so I think that will be important. But seriously, I think it's important that we tackle we compare and share our approaches to tackling an aging population where citizens stay healthy for longer. And it's as important in the UK as it is in India. And I think there's scope to share practice. Thank you for inviting me. I found the conversations fascinating, and there's a lot for us all to consider going forward. I'm looking forward to hearing more discussion and debate on this increasingly crucial topic. Before I finish, I should introduce you to my colleague, Richa Misra. She sat at the front in the red top. I think it's red, I'm colorblind, so who knows. But Richa heads the life sciences and chemicals sector at the British Deputy High Commission in Ahmedabad, and she's on hand to talk about possible trade, investment and collaborative opportunities in life sciences, should that be appropriate. So I'll finish by saying that I'm sure that the health and life sciences sectors in the UK and India, in the spirit of our deep and long-standing partnership, can work together to tackle future demographic challenges. And I wish you all the best of luck in approaching those challenges. Thank you.
Great. Thank you so much. And I think in your car journey tomorrow, I think yesterday the government, as part of their major conditions survey, recommitted to increasing the number of healthy years we live in the UK by 5 by 2035. And I think we'd argue that a really important part of that is investing in prevention and in preventative health. If we're going to keep people healthy, we have to do that. I love the point about the sort of the online stuff, because actually I think the health ministers here tomorrow are also attending the MedTech conference around the corner. And clearly there were real opportunities to use technologies to help people access health. On that point, we're about to, and the magic of technology, we wouldn't have been able to do this even a few years ago. Now, for a few minutes, head over to Germany and hopefully, and I'd like to introduce Anna-Katharina Hornich, who is the director of the German Institute for Development and Sustainability, who's going to talk about sort of the relationship between healthy living, healthy longer lives on a healthy planet. Can you hear us?
I can, thank you. It's a pleasure, David, and a pleasure being with all of you. Thank you for having me join online. I realize it's always not the full, so to say, experience for all involved, but I'm really grateful to be with you in India. I just came back 10 days ago and it was a little too much to fly out again. Allow me to share my slides. I'm planning to briefly speak about a just recently published flagship report by the German Council on Global Environmental Change Processes, with which we partly advise, of course, the German government. That's part of our mandate, as well as have brought these discussions into the G20 and Think 20 discussions, especially this year under India's presidency. So it's a real honor to be with you. I'm, as David already said, heading the German Institute of Development and Sustainability, and we've been tasked before for the German G20 presidency, as well as for the German G7 presidency, with organizing the advisory, the Think processes respectively. And I'm very happy to say that also this year we could contribute to the health discussions within the under the Indian presidency, as well as under the Japanese presidency for the G7. So I hope, could I just get a feedback? Can you see my full screen before?
Yeah, you can see it there.
Great, thanks. So I got 5 minutes by David, and I will speak about healthy living on a healthy planet. Basically, what I'm referring to is a flagship report that is also standing here next to me. It's of course downloadable. I'll show it on the screen in a minute. And the council that it has written is a council that is advising the German government on, in this report, on the interplay of environmental and climatic change processes, as well as health. Now, we first of all, of course, introduce the government and also here the policymakers on the club governance formats to the current situation. Our lifestyle is making us ill. I put a few numbers here onto the slides. We already heard quite a bit about non-communicable diseases, also about antimicrobial resistance. We are all expert in the field, but obviously there's an increasing sort of window of opportunity to also create a further awareness for the health hazards that arise from environmental risks. Nevertheless, our lifestyle is not only making us ill, but it's also destroying our ecosystems. We can all observe the very tangible effects of climate change by now. We know that, that our policy actions are not enough with regard to battling climate change. We also know that biodiversity loss is progressing. Now, the council then says, well, the existing healthcare systems very much take a curating approach, an approach that focuses on curing diseases, but indeed a substantially more prevention-oriented perspective is needed. So if you look at that circle, basically, I'm now sort of starting to talk about prevention and resilience. The council argues for establishing a vision called Healthy Living on a Healthy Planet, a vision that can guide national as well as regional, as well as, of course, then multilateral policy-making debates. Healthy living on a healthy planet requires a substantially more prevention and resilience-oriented perspective that understands people as part of nature, respects the planetary guardrails, fosters cross-system and trans-regional, transnational cooperation, and focuses on inclusive approaches, such as, for instance, celebrated by India's presidency within the G20 this year. The report then progresses to basically say, well, this sort of is followed up by stating, governments are asked to screen through their policy actions at the interface of environmental changes and health, by on the one side, looking at reaction and repair of damage-focused policy making, then prevention in order to reduce risks, health risks at that interface, and substantially invest into resilience through, of course, also then investing into healthcare systems, but also into health education, for instance. The report then argues for something that we called global urgency governance. It's a bit of a mouthful, one might want to say, especially in English, but a governance that understands those SDGs as part of the Agenda 2030 that have a clear reference to environmental and climatic change process, as well as health, as the basically core SDGs that develop then a lever and a spillover, positive spillover effects into other areas. As part of this global urgency governance, the Council argues for the establishment of a human right to a healthy environment. If you look at such a clear, basically, if you look at national constitutions globally that have, or internationally, that have already installed a clear statement towards healthy environments as a human right, then we see that this is the case in many countries, and in many ways you could say this is an area, especially also for Germany, for instance, where Germany can definitely learn from the international experience. Germany, but also the UK, if I may add, are amongst those countries that do not have a clear statement within their national constitution on that right to a healthy environment. So the proposition is to establish such a human right to a healthy environment as a guiding lamp, as a policy orientation, but also at the same time as not just an orienting, and not just offering orientation, but also a benchmark that can actually be monitored and then enforced. As a third element of this global urgency governance, the Council argues for the cooperative assumption of responsibility. So here it draws on the principle of common but differentiatedly shared responsibility that we all know from climate politics, and basically here argues that this shared responsibility has to be deciphered, the differentiatedness of it on the multilateral level, on the respective institutions here, also underlining the importance of the quadripartite approach between WHO, FAO, WOAH, and UNEP. Finally, and I come to my last slide, the report calls for leadership, and it calls for neither just political nor just economic leadership, but argues that there is such a thing as the interplay of political, economic, and intellectual leadership needed for establishing such a vision, healthy living on a healthy planet, as an international guiding frame, as also a focal point to reflect on during post 2030 or beyond 2030 discussions when we now think of the, for instance, upcoming SDG summit in New York, that slowly paves the way for thinking about a common agenda also after the year 2030. And despite geopolitical differences and tensions that exist, we argue that the urgency that we all have experienced also during the COVID-19 pandemic, and that we are experiencing now increasingly at the interface and due to the effects of climate change, creates a window of opportunity for fostering multilateral policy debates where we do manage to basically put geopolitical differences aside and focus on where we converge. And where we converge, of course, that is the area, or that is, well, healthy living on a healthy planet. We then argue that the different fora of the G20, also the G7, but also fora that are not officially global governance fora, such as the COP28, or also the Summit of the Future at the level of the UN, are important fora to basically sort of take a stepwise approach to building up the respective discussions and discourses, engage in the respective trans-regional dialogue to jointly think about making such a vision of healthy living on a healthy planet work, and also reflect on a human right to a healthy environment out of the many different national contexts and also regional contexts. With this, I thank you. The report is online in of course, English and German, and you can see here the website. I thank you for engaging with me on this.
Thank you so much. And one question we've had from a couple of people is, well, why did you include environment in your measure? And I think, and Katerina, you've highlighted exactly why it's important to include environment as one of the measures, because it's so interlinked. In the UK, there's a lot of talk of an idea of, and of course the US, this idea of a Green New Deal, so a policy framework around the environment. One thing that's worth saying is that, you know, we've been saying we need an aging society New Deal. For me, an aging society New Deal is exactly the same as a Green New Deal. It's basically good work, a nice place to live, and good health. And I think there actually is a real value for the environment sector and our sector to come together to highlight this is about people. So thank you so much for that. And we're going to move on to sort of a couple of presentations around life course immunization and healthy aging. And there's a point that Ruth Patel from Carers World makes in the chat around it's really important for us to keep not just keep younger people and keep older people healthy, but also keep carers healthy. If carers are playing part, it's extraordinarily important. And I was talking earlier to Professor Singh about this, and we were saying that, you know, look, actually, if we want older people to be looking after grandchildren, we need to keep older people healthy. If we want people, so it's extraordinarily important that we do think about health and prevention in the context of all ages. And of course, we did some, I remember seeing, we know that prevention starts very young. And Professor Singh's going to talk about this in a moment, but I remember seeing Professor Winston, who some of you will know from the UK, speak once, and he made the point that we start aging in the womb. So actually we need to start very, very young in terms of what we do. But before I pass on to Professor Singh for his keynote presentation, can I ask Esther to talk a little bit about the context? Do you want to use this microphone in case this, or do you think that one's going to work? Shall this one seems good.
So thank you very much, David. Thank you all for attending, and for those of you online. And to our panel of speakers, thank you so much for your presentations so far. So if we could go on to my next slide, thank you very much. So this project is looking at the cost effectiveness of life course immunization when we understand it at a population level and from a life course perspective. So my first slide here underpins all of this work that we've been doing across the G20, the G20, G7, and the World Health Assembly this year. So immunization is safe and effective and underused. As I say, this underpins everything we do in this project. We know that childhood vaccination in particular is one of the key triumphs of the 20th century. That's true in India, it's true in the UK, and it's true in countries across the globe. And we wonder if part of how we've got to where we are now with vaccines being underused is that we don't have proximity to vaccine preventable disease in the way that we used to. So many people, the older generations will have known people with polio or known people with German measles and all sorts of things that we don't tend to see as much now. So it's easy to forget and think, oh, that's sorted. Is this investment necessary? What is the value that we're getting back when we invest in immunization? Can I have my next slide, please? And we wonder if that's part of the picture when we see that particularly adult vaccination is lagging. One of the reasons we are investigating might explain this phenomenon is the difference in what we expect from adult and childhood immunization. We anticipate that adults will receive fewer immunizations than children. As you can see, there's differing World Health Organization uptake targets for adults and for children. This particular 75% figure is for influenza, which is a seasonal immunization, so that may form part of that as well. My next slide, please. Thank you. We know that where routine immunization continued throughout COVID-19, emphasis was still on the childhood. So in the 2 years, 2021 and 2022, 100 million fewer doses of some adult vaccines were delivered than we should expect. And when we're saying already we're not doing enough, not enough minus 100 million is not a good place to be. We also see that we have millions of symptomatic cases of flu each year in the European Union and European Economic Area, leading to tens of thousands of deaths per year that might be preventable through immunization. Could I have my next slide, please? So this graph is looking at COVID vaccine uptake across G20. I chose COVID for two reasons. One, the availability of the data, which surpasses all other vaccine preventable disease. And what was the other reason? And the second, the pandemic was a litmus test for each country's capacity to respond to a health emergency. You know, what was the state of our health infrastructure and what was the state of our pandemic preparedness measures? So you'll all have spotted your own country first, I imagine, and this is in alphabetical order. I considered doing a sort of traffic light system that tied in with the index, but I think there's so many factors behind how each of these numbers came to be that I think we'll hear a lot more over the next couple of years about how adult delivery of COVID-19 vaccines panned out. Could I have my next slide, please? So like I say, my key mission with this project is to put across the value of immunization to any G20, G7, World Health Assembly policymakers that might have encountered our work. And we can summarize the value of immunization in these 4 ways. So the first being possibly the most obvious: if we don't have flu or polio or German measles, we don't need to treat those things. So our healthcare systems aren't dealing with those people. The second piece of value would be the healthcare costs of secondary conditions following vaccine preventable disease. The example I've used here being incidence of cardiac events after respiratory infection. The third is keeping people productive, active, engaged, means measurable gains in terms of paid days of work, which obviously has an impact on GDP. And the fourth is everything else we do in our lives, our volunteering, our caring, our shopping, our everything else, which can be extremely hard to capture, but that doesn't mean it doesn't matter when we're calculating the value of immunization. Could I have my next slide, please? So the context of this presentation is the post-COVID world that we're living in. where all three of these figures from Europe are looking at our health spending pre-COVID. And when we look at them now, we can also factor in where we are now. So our healthcare professionals and health staff are burnt out and dealing with huge treatment backlogs. So this is the first piece we should be looking at, and the easiest thing to look at when we're looking at value of immunization. So we can see that in 2019, hospitalization due to pneumococcal disease cost the health service in England upwards of £700 million. And the Spanish healthcare system spent at least €134 million in 2015 alone on 4 vaccine preventable diseases in adults over 45. Next slide, please. But healthcare costs aren't the whole picture, as we can see here. At the very top of this graph, there's the light blue, which is the direct medical costs that I was just speaking about before. But we can see that they're only 2% of the overall spending from this case of a measles outbreak in the USA in 2018. The vast majority of the costs accrued during that time were due to the public health response. And we all remember this very clearly from COVID, but these losses were made prior as well. Can I have my next slide, please? So this slide essentially speaks to what I mentioned earlier. So we can just about measure our direct medical costs. We can estimate our absences from paid employment and our the sick pay that we may or may not receive in lieu of that. And that comes to the sum of $11.2 billion to the US economy in 2022. And what else is out there of all of the volunteering, caring, spending, and every other expense and every other interaction we have in our daily lives? How were they disrupted by flu and by various other vaccine preventable diseases? We can also see that flu cost the OECD countries around 159 million working days in 2018, just in the 50 to 64 age bracket alone. So my colleagues have spoken about work span and how getting us all staying in work and satisfactory employment for longer would definitely be a good thing. But, you know, that objective could be undermined by preventable disease. Next slide, please. And this is an important figure that is from 2018, so may need some updating. We know that every euro invested in vaccination generates at least a €4 return in future revenue. As we say, this is likely to be much higher. And how do we measure the time we spend with our families? How do we measure unpaid care and volunteering? How do we measure doing the things that we wish to be doing unimpeded by preventable disease? So this is hopefully in the making. Can I have my next slide, please? This work is all the more urgent in hindsight of COVID-19. We can see from this graph that emerging market and developing economies were hamstrung the most by the pandemic. And this leads us to question what might preventing disease through vaccination offer to the economy to assist with this recovery. Next slide, please. And the consequences of vaccine preventable disease, such as COVID-19, will stretch far into the future. And I've outlined 3 of them here. So we see inequalities in access to healthcare. We know that COVID cost the global economy $12.5 trillion, which is an amount of money I don't even understand, between 2020 and 2021. And that's still predicted to rise by 2025. And we also need have a long way to go in terms of trust between citizens, governments, and health systems with regard to immunization. Can I have my next slide, please? So it's difficult to measure cost effectiveness, but doing so can support decision making at all levels, particularly at the G20 level that we are engaging with at this event. There's plenty of data out there on cost effectiveness of various vaccines, but too often it's siloed by condition, region, and other characteristics that don't support a full understanding of what vaccination might offer, particularly in economic terms. Can I have my next slide, please? So this is my final concluding slide, just to say that ill health not only affects our own lives and families, but every aspect of our economy. So although I might go off sick from work, I would receive sick pay, I wouldn't travel or spend money in an ordinary way. And when we look at that on a global level, as we did through COVID-19, this total shutdown and the cost $12.5 trillion in the first 2 years, and the death and disruption that ensued, we know that we have a long way to go in terms of our pandemic preparedness and our investment in these technologies that can support prevention and can support improved health outcomes. So I'll stop there. Thank you very much.
Thank you. That's great. And actually, I think it's in some ways it's quite impressive that sort of, almost all of the G20 countries got to over 60% uptake around COVID vaccine in adults, particularly given in many countries there was no culture or particularly infrastructure around adults. And so actually what it's shown is we can build this infrastructure. We know, and Esther talked about the pandemic preparedness. Clearly that there is in New York at the UN General Assembly a high-level meeting taking place in September, and we'll be going along and doing something alongside it to make exactly this point. Actually, if we want to be prepared for future pandemics, we've got to make sure that everywhere across the world, not just the richest country in the world, everywhere has the facilities and the infrastructure to deliver vaccinations across the life course, and that includes practical things like having enough doctors, as well as the manufacturing capacity and things like that. So with that, I'm going to move from adults onto a real expert on children. We have Professor Singh, who is the director of the WHO Collaborating Centre for Paediatric Immunology, joining us, and we're very lucky to have you here and have a different perspective to what we normally have. But as I said, we're particularly keen to highlight the importance of prevention across the whole life course. So can I pass over to you?
Thank you, David. And I'm grateful to the organizers for having me here. Could I have my first slide, please? Yeah. So I am a pediatrician. I work as a pediatric immunologist at the Postgraduate Institute of Medical Education and Research at Chandigarh. And we are a WHO Collaborating Center for Pediatric Immunology. So continuing from where Mr. Hickling left, this topic is very dear to me as well, as I approach not my 49th birthday, but my 63rd birthday in a few days' time. And while preparing this talk, I think I learned many things which I was unaware of earlier. Next, please. So this concept of life course immunization is something which is not known to many pediatricians. When we talk of immunizations, I mean, we talk of young children. And immunization, for some reasons, has been synonymous with pediatric immunization, which is not the case any longer now. So now we talk of life course immunization. That means immunization spread across the lifespan of an individual. And this is a very important concept as our population is aging. And the earlier we realize and the earlier our governments start spending money on immunizations for adults and for the elderly, I think better it would be. Next slide, please. So what is life course immunization? This is the concept of vaccination to individuals throughout their lives at different stages and in varying circumstances. The goal is to provide immunity against a range of diseases that can be prevented through vaccination. Measles, hitherto was considered to be a childhood disease. We are now seeing adolescents with measles. We have seen some adults with measles. Polio, it is still not gone. There are still 3 countries in the world where polio is endemic. So we have to be on our guard. And were these 3 countries, I mean, if polio escapes from these 3 countries, we are going to have a major problem at our hands. Influenza, as many speakers, preceding speakers have talked about, it's totally ignored. In our own hospital, we are provided influenza vaccines for doctors, and a large chunk of these vaccines are not utilized by doctors, not by lay people. Next slide, please. So what is the importance of life course immunization? We have to be aware about the appearance of new diseases. Zika virus, COVID-19 was a bad experience, and re-emergence of old diseases, measles, pertussis, not in children, but in adults. There is necessity of prevention rather than treatment in the face of an aging population. And we have to know the concept of community immunity across a lifespan. We no longer use the term herd immunity. It is community immunity, not in the pediatric age group, but across a lifespan. Improvement of health outcomes and reduction of healthcare costs by preventing illnesses and complications that can arise from vaccine preventable diseases. As Esther said, €1 spent on immunization will give you dividends 4 times that the cost. In developing countries, maybe 10 times that cost. Next slide, please. So why do we need to vaccinate older adults and elderly individuals? By the year 2030, which is just 7 years from now, almost 1 billion individuals will be aged above 65 years. 1 billion individuals. And for the first time in the history of mankind, this age group will outnumber children below 5. So immunization till today was focusing on preschool children. But a few years from now, the elderly individuals will outnumber, individuals above 65 will outnumber children below 5, because many countries now are showing declines in birth rates. And even in India, our population is stable now. We are unlikely to show an increase in our population over the next few decades. And most developed countries are showing a decline in their growth rates. So increasingly, we have to concentrate on immunization of adults and the elderly individuals. Next, please. Many infectious diseases have their greatest incidence and severity in older adults. Influenza, pneumococcal disease, it's ignored in adults. When we talk of pneumococcal pneumonia, for most pediatricians and even for internists, it is a childhood disease, not any longer. Infectious diseases in older adults may also worsen existing comorbidities. As Esther mentioned, a patient may come with a respiratory illness and go on to have a cardiac event. Due to success of childhood vaccination programs, the burden of some infectious diseases has greatly decreased in children. Measles is the prime example, shifting the bulk of the disease burden to older individuals. And as a pediatrician, I can say that when some of these childhood diseases present in adults, the internists may find it that much more difficult to diagnose them because they're not used to picking up measles. They're not used to picking up whooping cough as we are used to. Secondly, the clinical presentation of some of these diseases in adults may be different from that in children. I have included the photograph of Sir William Osler, who died at the age of 70, not from a lifestyle disease, but from pneumonia. in 1919, and that pneumonia could well have been influenza or pneumococcal pneumonia. Next, please. The WHO recommends annual vaccination with the seasonal inactivated influenza vaccine for all individuals aged above 65 years. There are very few countries where this is practiced. All countries in the European Union recommend seasonal influenza vaccination to older age groups, and some countries define it as 50, others use a cutoff of 65. In the United States, there are recommendations for influenza, tetanus diphtheria or tetanus diphtheria pertussis, herpes zoster, which is a relatively new vaccine, and pneumococcal vaccines. In Australia and the United Kingdom, vaccines for influenza, herpes zoster, and pneumococcal vaccines are provided free to older adults. So concepts are changing, the programs are changing. Next, please. In 2012, the WHO made a rather revolutionary kind of recommendation. Influenza vaccine for pregnant women. I mean, it was unheard of, but yes, now they are recommending that. At present, in inactivated influenza, tetanus, and pertussis vaccines are recommended during pregnancy in several countries. Our generation, for pregnancy, we would just give tetanus vaccine. So nowadays, the repertoire is much wider. New vaccines are also being developed for maternal immunization to prevent neonatal infectious diseases such as respiratory syncytial virus and group B streptococcus, which can be killers. Next, please. So this is a cartoon showing how the concepts are changing, and the number of vaccines that we give to our children, of course, has gone up over the last 2 decades, but increasingly more and more vaccines are now being recommended for pregnant women, for adults, and for the elderly. Next, please. Like any other national program or an international program, there are several barriers to life course vaccination. The most critical barrier is complacency. We think that as doctors, if a child has received his normal set of vaccines, he's protected for life. Even doctors think so. They don't take adult vaccination as seriously as pediatricians do. Challenges in vaccinating special populations. In the elderly, they may be in old age homes. They may be in situations where the doctors can't reach them. There may be problems of inaccessibility, ignorance, even amongst doctors, even amongst the medical fraternity. Cultural acceptance. It's easy for us to convince mothers that a child needs vaccination. You try convincing her that her parents need vaccination too. It will be difficult. Next, please. The COVID pandemic taught us many things. Number one, there was disruption of the routine vaccination services. So the vaccine uptake of the routine scheduled vaccines went down several slots. There was repurposing of health resources, decreased demand for vaccines because many mothers just would not dare to take their children outside their homes. And there was shortage of vaccine supplies. There was delayed introduction of new vaccines, interruption of clinical trials, and regulatory approvals for understandable reasons. Next, please. The concerns about vaccination reflect the perceptions about vaccination in specific cultures. Vaccination acceptance depends on local context, and interdisciplinary approach may enhance the capacity of other health professionals. And this is where pediatricians can take leadership roles. because for us, vaccines are part of our day-to-day professional work. And we have to engage with internists. We have to engage with geriatric specialists to ensure that the adults and the elderly are not left uncovered. Next, please. So there have been many changes, and to incorporate these changes into our daily practice, we need some paradigm shifts in our thought process. So we have to provide vaccines, vaccine convenience for adults, and concept of vaccinating at the workplace. Because for an adult to go for a vaccine, it may mean loss of wages. Collaborations with pharmaceutical companies, addressing vaccine concerns and limiting vaccine hesitancy. Making the concept of life course vaccination a social norm for a healthy lifestyle. I think this is what needs to be understood. Next, please. The COVID also taught us that we need to invest in research on new vaccines and delivery systems. And the COVID research, I think, was a very good example of what science can do in a very short time. We need to incorporate technology for better techniques of administration, better vaccines. We need to have global collaborations, vaccine equity, so that the less served countries in the world do not suffer. Education and communication, and pandemic preparedness. The next pandemic may only be a few years away. Next, please. So for an adult and for the elderly, the pillars of healthy living do not depend only on healthy food habits and physical activity and exercise, but life course immunization is an integral part of good health. And this is something I think which we need to emphasize over and over again in school curricula, in medical school curricula, because this is something which is missing even from the our National Medical Council guidelines. They do not talk of life course immunization. So we need to work in tandem with the educators and incorporate these concepts into medical education. Next, please. India is uniquely placed for taking a leadership role in this field. And the COVID pandemic, I think, was a good example of what India can do. Next, please. India is the largest vaccine producer in the world. It contributes 60% of global vaccine supply. Indian producers supply 1.5 billion doses annually to more than 150 countries, including many developed countries. It is the largest supplier of DPT, BCG, and measles vaccines globally. The World Health Organization sources 70% of its essential immunization vaccines from our country. Next, please. So these are some of the major vaccine manufacturers, and the Serum Institute of India, led by the Cyrus Poonawalla group, I think it did yeoman service during the pandemic, and the work done at this institute, I think, was responsible for saving virtually millions of lives, not in India, but across the world. Next, please. And India took up leadership role. India in 2021 started a diplomatic mission named Vaccine Maitri, an initiative to provide COVID-19 vaccines to low-income countries gratis. And later on, even developed nations were included in this policy. Next, please. So these were some of the countries where vaccines produced within our country were supplied during the COVID pandemic. The message that I want to give is that money spent on vaccination is money well spent. And vaccination should not be taken as an expenditure, as a burden for the country. Rather, it is an investment for the future. And when we talk of vaccination, we talk of vaccination of children, we talk of vaccination of adolescents, of adults, and now of the elderly. So elderly vaccination and adult vaccination is as important as childhood vaccination. Next slide, please. So we are the largest, the COVID-19 vaccination drive in India was the world's largest vaccination drive ever in the history of mankind. So these are some of the steps that India took. I think we managed the COVID-19 much better than many other countries. And the major credit for this goes to our vaccination policy during the pandemic. Next, please. Thank you very much.
No, and that number at the end highlights, simply the number of doses, just astonishing number and a number that were introduced in India. Your point about pertussis, I thought really important in that, of course, the reason WHO recommended vaccinating mothers against pertussis was not really to protect the mother, it was to protect the baby who couldn't be protected in the first 8 or 9 weeks. Similarly, in the UK, we vaccinate teenagers against influenza, not because they're particularly likely to be heavily hit, but because teenagers spread germs to grandparents quite a lot. So it's really, really important. I think there is absolutely clearly a point about the COVID pulling the focus away from other conditions, but on the other hand, of course, we do have new RSV vaccines, we have new vaccines on C. difficile, we have new potentially really exciting innovations coming as well that could transform even further health for younger as well as older. I'm very conscious that there is food waiting for us, but I also am conscious we've talked to our audience here. So I am going to keep us going for a few minutes. If there are people in the audience who want to say something, if you do wave your hand very quickly. No one wants to jump up. Go on, we've got someone here. If you give your name and your point, and it can be a question or a comment, but not too long as we're keeping people away from their food. Try that one, yeah.
So my name is Abhinav, and I work for GlaxoSmithKline. I lead the government affairs policy advocacy portfolio. I've been in FMCG space and then moved to pharma. I have the reports and everything presented were incredible. And I think everything, the way Professor Surjit said, I think we are moving in positive direction. Sir, only one question I have. In India, if doctors are convinced, then everyone around them gets convinced. What is the reason that why doctors are hesitant in taking vaccine? Why they don't take it? Because once they take it, then they can recommend to their patients or people around them. So that's the question I wanted to know. What is the reason of hesitancy there?
I think it is just complacency. And the way we have been taught in our medical schools, things have to change. So in our medical schools, still, vaccination means pediatric vaccination. So that concept has to change. And as adults, whether we are doctors or, we are just complacent that others fall sick. We don't. As doctors, we don't fall sick. As simple as that.
Thank you so much. We've got a couple more over here. Go on, Lilies can.
Hi, I'm Venkat. I work with PATH. And I don't have a question, but I have a thought to share. So when we talk of life course immunization, and when we want to learn from COVID-19, we also need to look at the point of equitable access. Because when you talk of life course vaccination or life course immunization, the big question is at the end of it, who pays? And we know there are a lot of LMICs which don't have the capability to pay. So when you look at life course immunization, you need to look at pathogens which might be endemic right now, but which have the pandemic potential, the one that has been identified by WHO in its prioritization list. And when we look at vaccines or vaccines for those pathogens, I think then we should treat vaccines as public good, not as private good. And that's where we need to look at, democratizing vaccine manufacturing, look at, democratizing or even co-development of vaccines between, various geographies in the world, and, look at also harmonizing the regulatory process. The point that was brought forward that, when COVID-19 happened, regulatory harmonization was one of the biggest challenges. So I think we need to look at these so that when we look at life course vaccination, life course immunization, when it finally reaches the people, and when it goes through the government system, the public health system, it goes at the lowest cost to the system as low as possible. So that's my thought. Thank you.
Great. Let me bring in, there was someone else at the back, and while Lily's passing over, I think, I suppose I'd say one of the really interesting questions and challenges there is, we don't say we're in terms of childhood vaccine, what's the cost effectiveness? And I think we have to be very careful that the reason we're investing in health is because it is good to do so as well. So there's a social value of doing so. So whilst we as ILC are very much pushing the economic costs, because that's what politicians care about. But there is a case for us all across all ages to invest in health. Please.
My name is Aman. I lead a company called SPAG. I think I've been in the public health system now for almost more than 2 decades. And one thing which I believe this topic requires is a focus on advocating, educating, and sensitizing the different stakeholders. As Dr. Sujit said, that even in the medical fraternity, if there is a complacency, what we are really looking at is a behavioral change. And especially in the adult immunization side of it, I think long time back, I worked with MSD, and they were one of the first ones to bring the whole adult immunization concept in here. So I think one of the role in which I think ILC could play is to bring different stakeholders to say, how can we take this conversation in from this room into a larger public discourse where we are able to use the right influential voices to engage with the different decision makers to say why this is kind of required, the way you have, and I think it's not just adult immunization, whether it is the pediatric immunization, but I think I really love the whole concept of the life, kind of a whole life immunization space. I don't think any of the individuals really think it in that way. It's still a very, very, to a strict group. So I would say the focus on using communication and advocacy as a tool could really play a critical role in this space.
Great. It's a really useful point, and we'll take that away. The lady next to you, and then the lady.
Thank you. Aparna Krishnan from JPAL. Question for the ILC team as you were doing the index, Healthy Aging Index. I was wondering if you had any observations or patterns on the intersection of gender and aging, and if how women may be differentially impacted by aging. And the reason I ask this also is because we have a longitudinal survey ongoing in Tamil Nadu with the government, and one of the striking findings was a growing proportion of elderly living alone, and a large majority of them happen to be women. And so that has implications on social protection interventions, access to healthcare. So I was just curious on if you had any observations from the data collection and what you think may need to be done differently, if at all.
Great. Aaron, do you want to come up?
Yeah, thank you for your question. And first of all, I mean, when we looked at the index, we didn't specifically look at gender, although I know it's a driving force for a lot of these issues. I presented on education. Again, that's very much a gendered issue. So we have to recognize that it's less likely that girls are making up that statistic than it is that boys are. And when it comes to healthy aging in and of itself, we know that women are likely to be in poorer health than men are for a longer period of their life. So I think all of these questions are sort of embedded in the work that we've done, but we haven't actually looked specifically by gender. But this is something that I am keen on doing, especially when we're looking at specific conditions that are very much driven by gender differences.
Thanks. Yeah, my guess would be if we did better with women's health, you would do better on on
evening,
our
all.
table.
I am Dr. Pradnya Digika, Professor of Medicine in Dr. D.Y. Patil Medical College, Pune, and I am a geriatrician, and I conduct camps, health camps, just to educate the society and my students also. So I found in COVID, the people were just adult were concentrating on the COVID first dose, second dose, and booster dose. But then I thought that they are not knowing about the pneumococcal and influenza vaccination. So what I did, I have prepared the posters for they were prepared by the students, and the injection vials were there. So the name of the vaccine was there, the side effects and dose was there, and how to take it, and what are the side effects. So those were visiting in our hospital, they were knowing what are the name of the vaccine, indication of the vaccine, and your age. So this is the one criteria. And second, I have given the lecture. So the lecture was prepared like that. The elderly, my target was adult immunization, because they were not taking pneumococcal also vaccine and influenza. So then I have targeted that part of the people, means elderly, and prepared a vaccination card for that. There is a card for pediatrician, but there is no card for the geriatrician or adults. So this idea I have prepared, and on that part I have prepared that immunization card for elderly. So those students who are flying for the education, they are going to other countries, they have to take the immunization, particularly immunization. Otherwise, they will not get the admission. That was one. Then my health workers, they are working in the ICUs, and so I immunized them for the influenza vaccine. And that Zydus people, they gave me at 750 rupees. It was 2,200. So he gave me in the concession. And then my residents, third-year residents, they were there. So whenever you conduct it may be 2 minutes, Aruna, but I just wanted to know that. So this can happen. So you can educate the doctors also. So because they are not knowing, even my CEO was not knowing about the pneumococcal and zoster vaccine. So he said, you go. So he has given me the letter, and I attended the IFA conference at Bangkok. And my topic was challenges in the immunization. So I think at this platform, I will be requesting to prepare a geriatric adult immunization card. So if you give that adult immunization, everyone will know that this is the dose and this is the way we have to give the injection. So that is the one part. And second part, if you in the children, if you ask them to attend any elderly in your society, you just go and talk with them. You just go and talk with them on your hours. So whenever they will be old, someone will come to them, and the communication or problems will be discussed. Thank you so much.
Thank you. And I think we were talking about this a little bit earlier. So I had to have a few vaccines before I came here, and I went into the place and they were like, so what have you already had? And I said, well, I have no idea. They had no idea. It's been, no one knew if I had tetanus or diphtheria, or if I'd had hepatitis A, or if I'd had no one. So it's terrible that we just don't keep these well in adulthood, and we need to do this better. And it's a global challenge. I was going to ask, just to finish, before I do a couple of final comments for 30 seconds, Mr. Umranika, just any final comments, if that's okay, just to, and a huge thank you again to ILC. This is the first time ILC-UK have come over to India, and first time we've worked with our colleagues in India, and we're really, really excited, and we couldn't have done it without you. So I just thought I would say both a quick thank you, but let you have some final remarks, if that's okay.
At the outset, of course, I would like to thank all of you for organizing this event. Wonderful event and wonderful lectures we heard. And the first two questions, the first question and one observation, both of them very intriguing. Would you like to ask what you said to GSK? democratization of vaccines. What will be his response? Because this has been the theme in India, especially for a very, very long time. And I think it will be his corporate responsibility to see to it that democratization happens at some stage at least.
Thank you so much. I think I'm going to finish there, Lily. Is that okay? Oh, is there, well, okay, good. Thank you all so much. We do, for those of you here, we do have some food in the room next door, and I really hope we will carry on the conversation, not least because I really don't want this food to go to waste. And I'm very, very keen for us to have this carry on talking. So please come, and those of you in the room, come and have a chat at just around the corner. Thanks again for those of you online, and thank you for all coming in here, and thank you to ILC India. And we hope that the Health Ministers meeting and Stephen's conversation in the car will be very fruitful tomorrow. And actually, as I think was mentioned by Professor Singh, there is a real, economic opportunity here. India is a huge manufacturer. India has some real expertise, but so does the UK. And actually, how can the two countries work together in this space? And I think there is very significant opportunities. So thank you all, and I will stop, and we will join you outside for some food. Thank you.